Good afternoon or evening, wherever you are, and welcome to our TIF Talk Tuesday. Thank you for joining us today. My name is Andrea Millers, and I'm with Endogastric Solutions. Today, we have a very special guest, Dr. David Dargis. Welcome, Dr. Dargis, and thank you for being here with us today.
Absolutely. It's a pleasure to be here.
Thank you. So let me give you a little background on Dr. Dargis. He is a board-certified general surgeon. He earned his medical degree from Philadelphia College of Osteopathic Medicine in Pennsylvania and completed his general surgery residency at Botsford General Hospital in Farmington Hills, Michigan. Dr. Dargis is a fellow of the American College of Osteopathic Surgeons. His clinical interests include minimally invasive surgery, endoscopy, foregut and anti-reflux surgery, and gastrointestinal surgery. Dr. Dargis is at Spectrum Health in Hastings, Michigan. So again, welcome, Dr. Dargis, and thank you for being here today.
Oh, it's a pleasure.
So this is a live event, as you all know if you're watching. At any time, if you have any questions, please feel free to comment. Type your question in the comment section, and we will do our best to answer your questions tonight. So let's go ahead and start, Dr. Dargis. Can you kind of tell us a little bit? I mean, you've been doing TIF for quite some time now. How long have you been doing the TIF procedure now?
My first TIF procedure was performed in February of 2009.
Okay. Yeah, so been doing, and it's been doing it for a while. And my understanding, you have over 200, 230 or so procedures under your belt. Is that correct?
Correct.
Yeah, wonderful, wonderful. So, let's go ahead and start and talk about GERD. Can you kind of give our viewers an explanation of what GERD is and what types of symptoms could patients potentially feel and or complain about if they are suffering from GERD or chronic acid reflux?
I'd like to start out talking a bit about anatomic structures.
Perfect.
And we'll start that with the pump, which is the esophagus. It has motility, it has salivary secretions to it, gravity, anatomy plays into that. And then we have the valve, which controls, it has a pressure to it, has a length and a position. And that's the divider between the esophagus and then the reservoir, the stomach itself. It has a pressure, it dilates, it empties, it secretes acid, secretes fluid. There's some terms we're going to relate to relative to the gastroesophageal junction. We'll refer to that as the Z line or the LES, but those are common anatomic terms that we use. But GERD stands for gastroesophageal reflux disease. And it occurs when, acid reflux occurs when stomach fluids back up or reflux into the esophagus, exposing the esophagus to gastric acid. Typically, the typical symptoms of reflux would be heartburn and regurgitation. That's probably what I see most.
Sure.
But we more recently are thinking about atypical signs and symptoms like chest pain, difficulty swallowing, painful swallowing, chronic cough, asthma, laryngitis. Those are some of the atypical symptoms. Relative to reflux, people normally reflux. When you have too much fluid or too much air in the stomach, you may burp. Or when things get severe, you may throw up. That's a normal physiologic response. But when it becomes more frequent and it starts to bother one's lifestyle or it wakes you up at night, you can't sleep. You have to sleep upright in an upright recliner. Those symptoms can get cumbersome, and that's where we tend to want to intervene. And from a physiologic standpoint, we evolved something called esophagitis. That acid starts to irritate the lining of the esophagus. The stomach is very well designed to handle acid. The esophagus is not. And when you reflux something very acidic into the esophagus, it can create typical or atypical symptoms.
Right.
So that esophagitis is inflammation of the esophagus, which may be acute, it may happen suddenly, or it may be chronic over the course of years. Sometimes people will evolve some common esophagitis, such as ulcerations or bleeding, hemorrhagic ulcers. Sometimes they can involve stricture or scar tissue, which makes it difficult to swallow. And Barrett's esophagus is a precancerous condition that is kind of off to it. That's something else that can evolve over time. And can evolve into adenocarcinoma. So those are all the things that we will think about.
Yeah, yeah. So typically, you probably see these patients later on in their progression of GERD, if you will, as a surgeon. But when you see these patients, or if you talk to patients and they initially kind of start feeling those, frequent GERD symptoms, what do you normally tell patients to do to manage their symptoms? Are there lifestyle changes that they can do initially? Are there, foods to avoid? Are there certain things that they can do to kind of help that before they even get into medical therapy and or any surgical therapy?
Lifestyle modification is where we'll begin, and that could be inclusive of eliminating foods that trigger the symptoms, alcohols, timing of your meals, not eating 2 hours before you go to sleep or lay down. Weight loss is a large one, trying to get your BMI or your weight down to an ideal. Smoking can have an association with reflux symptoms. And your sleeping position, elevating the head of your bed, 2 pillows, but actually putting a cinder block over the head of the under the head of the bed can help. So those are where we typically will start, and then that migrates into medications. And typically those medications will start with antacids, neutralizing or buffering that stomach acid, with things like Tums, Mylanta, Alka-Seltzer, common over-the-counter medications. And then that typically will escalate into H2 blockers, of course, with ranitidine being taken off the market now, will escalate to the PPIs, such as, that was popularized by the purple pill years ago.
Right.
Nexium, Prilosec is the big one, very commonly available over the counter. Zagrib are some of the others. Dexalant's kind of the new kid on the block.
Yeah.
So about 90% of the patients that I'll see on an initial consultation have been on a PPI for over 5 years.
Mm.
And typically it will be double, if not triple, the recommended FDA dose.
Mm.
So these people have been on these medications for quite some time. And, a common phraseology that I hear is they're sick and tired of being sick and tired.
Yeah.
And it's a frustration that I see with many patients.
Yeah. So, you discussed all of, you had mentioned about the PPIs and being on them for over 5 years or whatnot, and patients still not getting the relief that they need, even on their PPIs. There's a lot of debate on, having patients on PPIs for a long period of time and long-term side effects. Can you discuss that a little bit more with us?
Yeah, there was a Canadian, it came out of Canada. It was done probably 8 or 10 years ago now, and it studied 40,000 patients. And the initial and most dramatic side effect that was seen was a 150% increase in osteoporotic related fractures, long bone fractures. And when you look, for instance, at hip fractures, and there being a 10 to 20% mortality rate within the first year of having a hip fracture, pretty alarming data. And the science behind that was that you need calcium for bone growth and strength. And what was found was that the PPIs, particularly the PPIs, it neutralized the acid in the stomach, but hence you couldn't absorb the calcium needed to grow strong and healthy bones. So to bone weakness and a higher rate of osteoporotic bone-related fractures. Other side effects that we have found over time, vitamin B12 deficiency, an increased risk of acquired pneumonias, reduced gallbladder motility by 10%, increased risk of C. diff, small intestine bacterial growth, magnesium deficiency, an increased risk of bacterial gastroenteritis. And there's some questionable studies about the interaction with Plavix. More recent studies, renal function and dementia. So there's a multiplicity of side effects that we are coming to know well and above and beyond the osteoporotic-related fracture issue. Okay. So I tend to, and these are all, this was data that was strong enough where the FDA has included a black box warning in the PPIs. So if you, next time you purchase a box, you can take a look at the insert.
Yeah, no, that's a good point. And it's interesting how, patients, will start feeling some sort of acid reflux or whatnot, and they'll start, self-prescribing without, asking their doctor if it's smart for them to take, if it's right for them to be taking, the Prilosec or the over-the-counter stuff, and then they just end up taking them for a very long time, and then you get someone that's been on it for 5 years, right? And it's still not working.
It was worsened by the fact that, it went over the counter. So a lot of people don't heed that advice to see your physician if it lasts more than, 2 weeks or a month.
Exactly. So we have quite a few questions that have popped up. So I'm going to go ahead and get to those, and then we'll continue with what we're discussing. So we've got a question from Corleen. She's asking, can you please discuss the difference between bile reflux and acid reflux? Would the TIF procedure help with bile reflux? My problem started after gallbladder removal surgery.
I see bile reflux, probably 5% of the patients that I assess for reflux have got a component of bile reflux. And you have to understand something, a little bit about the anatomy. Bile acid is secreted in the stomach. Bile is excreted from the liver, and it comes down into the duodenum, which is the small bowel piece just beyond the stomach. When you have excessive bile production, or you have maybe a loose pylorus, which is the juncture between the stomach and the duodenum, the small bowel, you can have some of that bile reflux into the stomach, and hence reflux up into the esophagus. The big difference between acid secretion and bile secretion is that it's basic. And the way I describe it to patients is that it's like snowball. It's a cleanser. It's a base.
Okay.
So any kind of acid suppression therapy isn't going to be effective against bile reflux. Mm. The initial treatment for bile reflux, and one of the pathognomonic ways that I will approach a patient with suspected bile reflux, is to treat them with Carafate, which coats the stomach. And if you have a clinical response from Carafate, it's an indicator that it may be bile reflux. The other way that you can differentiate bile reflux versus acid reflux, and one of the reasons, and we'll talk about it shortly, is the workup, which is inclusive of a pH Bravo study. Right. And those without getting into too much detail, because it's a complex test, It's a small monitor that's placed above the GE junction, and it will measure the amount of acid that comes up. And there's something called the Demeester score. And we look at scores of 13 or greater being abnormal, which is acidic reflux.
Mhm.
But if we see subnormal numbers, 2.3, 3.5, 6, well, that 6 is pushing a little bit, but low numbers, that's more indicative of bile reflux.
Okay.
But
So the
that's
question, yeah. So the question she has is, would the TIF procedure help with bile reflux?
the answer is yes, it would. It would help as efficaciously as with acid reflux.
Okay, wonderful. We have another question. Jamie's asking, I was diagnosed with GERD 5 years ago. Can I still get the TIF if my main symptoms are feeling of not being able to take a deep breath?
That would need to be worked up.
Yeah.
Not being able to take a deep breath, is it discomfort that you're feeling? Is it shortness of breath, difficulty breathing? Those are there's many other things that can cause that symptom. I would say in the 230 or so that I've done, I've probably seen 2 or 3 patients with that symptom as an associated symptom. But again, I would lean on that pH Bravo study to help differentiate that symptom with the reflux, because as part of that pH Bravo study, not only does it measure the acid coming up, it gives us what's called a Demeester score, but it also gives us a symptom association where you actually push a little button every time that you feel that symptom, and we can actually see if there's a relation between the symptom and the reflux of acid. So that's probably where I would go to help delineate the answer to the question.
Perfect. Thank you. Another question about GERD, is asthma a common side effect of GERD? Can the TIF help with that?
The answer is yes. It's one of the more typical atypical symptoms that I'll address with patients. And I'm seeing more and more from ear, nose, and throat, particular to something called LPR, or laryngeal pharyngeal reflux. And one of the comments, from an anatomic standpoint, as acid trickles up the esophagus, especially when you're lying down, it can trickle onto and irritate the vocal cords, which can exacerbate or worsen asthmatic symptoms. It may be the root cause, it may be an associated worsening symptom of it, but the answer to that question is yes. Tightening that valve, fixing that valve, lessening the reflux, in many cases can help asthmatic patients.
Wonderful, thank you. So you did talk a little bit about the Bravo pH testing. Let's go ahead and talk about all of the other diagnostic tests that you would potentially do for a patient to determine whether or not they're a candidate, for surgical treatment options. You can go into detail about those different tests.
Sure. In my particular practice, there are essentially 4 tests that we will obtain prior, and to better assess which procedure is best for you, and to better delineate whether the symptoms are related to the reflux. We typically start with an upper scope, an esophagogastroduodenoscopy, fancy medical word there, but an EGD. In that EGD, we'll take a look down, and typically I will biopsy the GE junction to better, regardless of how it looks, we'll send pieces of tissue to the pathologist so that he can better decipher how severe the esophagitis is, if it's existent. We'll then go into the stomach and rule out any stomach ulcers, and into the duodenum, where the stomach empties into the small bowel, make sure there's no duodenal ulceration, polyps, other conditions, Barrett's. And then typically I'll retroflexoscope and look at the valve. And I will grade valve with something called a Hill grade from 1 to 4. Hill being Hill 1 being essentially normal, and then Hill grade 4 being a very loose valve. But in doing the upper scope, we essentially look at the degree of esophagitis and can best assess the size, width, dimensions of the hiatal hernia. After we do the upper scope, we assess the biopsy results. I'll typically see the patient back, and we'll proceed with the EGD and pH Bravo. Just to backpedal a little bit on the EGD, it's an outpatient procedure. You come in and go home the same day. And typically I'll take pictures and we talk about those before you go home. But beyond that, we'll then proceed with the pH Bravo, which is essentially the same procedure. We take a look down, but this time we place a small, tiny little, it's about 8 millimeters in length. It's a tiny little capsule that's placed affixed esophagus just above the GE junction that will measure the amount of acid coming up and allow us to assess symptom association. It's an outpatient procedure. Again, we'll take pictures and talk about them. But what's more important in that test is the Demeter score and the numbers that we obtain from that device. One of the challenges of that workup, as far as the EGD with pH Bravo, is that you have to be off of all your medications for your stomach for 10 days prior to the study.
Right.
And to have us get a better assessment of just how severe the reflux is. And but that can be challenging for many, many patients. Probably one of the more major complaints, if you will, of obtaining the test. And then a third test would be the high resolution motility study. There's a minority of patients that have what's called achalasia, which can create some of the very similar symptoms, but have nothing to do with reflux. It has to do with how well it functions in getting food and liquids from the mouth down into the stomach. And the way that test is performed is just they numb up the back of your nose, place a small catheter down into the stomach, and then have you swallow 10 times, pull the catheter out, and you go home. But that gives us some really good information on how well the esophagus is working. Achalasia is essentially a contraindication to doing the TIF. We want to make sure, because if you do a TIF with achalasia, it will typically make the symptoms worse. So it's something that we want to make sure that we rule out before we proceed. And then the fourth and final component of the workup that I obtained prior to a TIF is the gastric emptying study, where you eat a sandwich and they take some pictures while your stomach empties. I'm seeing more and more of it, especially in diabetics, where you have a slow stomach, something called gastroparesis. And again, a component of that, but the treatment for gastroparesis is very separate and distinct from an anti-reflux procedure. So it's another thing that we want to rule out before we proceed. So for EGD with pH Bravo, manometry, and the gastric emptying study.
Wonderful. Yeah, thank you. So let's talk a little bit about the TIF procedure. Actually, before we go into the TIF procedure, maybe you can discuss what are the different treatment options, the surgical treatment options that are available. Some people that are watching are very educated and know that, the difference between the Nissen and TIF and whatnot. But maybe you can go into that a little bit in detail, all the different treatment options that are currently available at this time.
The surgical treatment, I'll divide this up into surgical treatments and endoluminal therapies.
Perfect.
Surgical therapies are done essentially through the stomach, through small, typically laparoscopic incisions where we enter the belly and work through the belly. And then the endoluminal approaches are ones that we do through the mouth, no incisions. Surgical procedures, I will talk about the Nissen fundoplication, which is essentially taking the upper portion of the stomach and wrapping it around the valve, which is fairly extensive. It takes about an hour and a half to 2 hours under general anesthetic. But it is very effective, 95% patient satisfaction. However, I caution patients because of the side effect profile of the Nissen. Even in Tom DeMeester and Jeff Peters' hands at the University of Southern California, their data, and Tom DeMeester was the grandfather of the Nissen fundoplication, even in their hands, the side effect profile was very high, upwards of 40% of patients with dysphagia, and abdominal bloat, gas bloat, where you kind of feel pregnant after you eat. So when you look at that high side effect profile, it really warrants a caution against proceeding with that type of procedure. Now, earlier I talked about a Hill grade, grading the valve, and a Hill grade 4 being very large. Sometimes the hiatal hernia is so large that we really proceed with an endoluminal therapy, and we're limited to do the Nissen. A toupee is, a Nissen is basically a 360-degree wrap, where we wrap around the esophagus 360 degrees. And there's the toupee, which is a partial wrap, again done laparoscopically, more in tune to patients with achalasia. That's kind of a side, I won't go into in length here. But those, the other interventional therapy is the LINX, which is a magnetic bead that's placed around the esophagus. And I'm somewhat cautious I don't do those. I was somewhat cautious to get started with those because some of the studies early on showed some issues with erosion and having to take the magnetic beads out. So I was approached to try and initiate that process, but I waited for the data, and I've been kind of cautiously conservative on that. So then we'll talk a little about the endoluminal approaches, inclusive of the stretta, which is an RFA, radiofrequency ablative technique, where there's actually energy that's injected into the lining of the esophagus, which essentially creates some scar tissue and tightens the valve that way. It's safe, it's effective. The other approach is the TIF procedure, which has been pretty embellished into my practice for quite a few years here. But those are some of the approaches that we'll commonly talk about relative to tightening the valve. The endoluminal approaches, again, there are measurements made of the hiatal hernia, and again, without going into too much detail, a medium or smaller sized hiatal hernia is very amenable to the endoluminal approach, but it's very important, and I'll dovetail back into the workup as to why we need to get an EGD in the PH Bravo studies to better assess that hiatal hernia.
Perfect. Yeah, that's a good explanation. So let's go ahead and start talking about the TIF procedure. Why don't you give us some detail on how does the TIF procedure work, and what's the mechanism of action for the TIF procedure?
It's an endoluminal approach, so it's done through the mouth, and essentially the GE junction and pull it down from the diaphragm, which kind of holds the stomach down from the lung. It's kind of a muscle that encompasses the stomach in the upper portion of the stomach. And essentially, we take that mucosa, we take that lining of the esophagus down, and then join it up with the serosal, the outside lining of the stomach, and we place fasteners essentially degrees around circumferentially, We use 16 to 20 fasteners to help bolster those layers and allow for 12 to 14 days of what's called serosal fusion to help that scar in, if you will. And essentially, we restore the valve. We have a video of that.
We do. Yep. Well, we can go ahead and play the video. And I believe it has sound as well. So.
The esophagus technology is designed to rebuild the valve from inside the stomach using a transoral approach, with the goal of creating a partial fundoplication that measures 270 degrees in circumference and 3 centimeters in length. An endoscope is inserted into the center channel of the esophagus device and provides direct visualization for the TIF procedure. While under general anesthesia, the device and endoscope are gently glided through the patient's mouth and into the stomach. The stomach is inflated and the endoscope is advanced and retroflexed so that it is looking up at the gastroesophageal junction. The valve reconstruction starts with the engagement of the helical retractor at the gastroesophageal junction. Then, tissue is retracted into the tissue mold as the esophagus device is rotated, wrapping the fundus toward the lesser curvature of the stomach. A small hiatal hernia can be reduced and the intra-abdominal length of the esophagus can be restored using suction built into the device. The trigger handle deploys a pair of non-absorbable polypropylene H fasteners above the GEJ to oppose the fundus to the esophagus. This retract, wrap, oppose process is repeated in specific locations to ultimately create an omega-shaped valve. Approximately 20 serosa fuse fasteners are placed during the procedure to recreate physiological anatomy and help prevent refluxate from entering the esophagus. Studies show that in the weeks following, serosal fusion occurs by creating a layer of fibrous and fibroelastic tissue that secures the full thickness plication. Clinical efficacy and durability of the valve have been confirmed in randomized long-term and sham-controlled studies. Well-selected TIF patients report consistent, durable symptom control, and physicians have noted improvements on objective diagnostic measurements. The TIF procedure has an exemplary safety profile and avoids uncomfortable long-term side effects associated with traditional fundoplication.
So do you want to comment on the animation that Dr. Dargis?
Yes, it's an endoluminal therapy that we do under general anesthesia. You come in that morning, we do the general anesthetic, do the procedure. It takes, in my own hands, about 45 minutes to do the procedure. I do keep patients overnight in the hospital, and predominantly to control any reactions that we'll have to help prevent any nausea or vomiting. But it's a very well-tolerated procedure. I'd say 90% of the time, you'll wake up essentially with no discomfort. The nurses often will ask me, why is this patient staying? They do really well. And with really no post-op narcotic needed. They do this procedure is very well tolerated.
So, if they just have the TIF procedure alone versus as far as recovery goes, versus having the hiatal hernia and TIF procedure combined, is there a difference in their recovery?
Well, you're talking about what we call a hybrid procedure, where we may tighten the crura. I won't get into too much detail there, but when they have a really large hernia, we may do that combination of a crura repair and the TIF over it. That recovery requires some laparoscopic incisions, so you'll have a little more discomfort from those incisions. But both are very well tolerated.
Okay, wonderful. So let's talk a little bit about the post-op regimen that you have your patients, from diet all the way to, when can they go back to work? What about exercise? I get a lot of those questions all the time. What do you generally tell your patients after they've had the procedure?
Initially, within the first 3 days, we'll recommend water, milk, decaffeinated tea, diet decaffeinated drinks, but typically non-carbon, broth, strained soups, apple juice, white grape juice, not acidic vegetable juice, puddings, creams, sherbets, and then that'll escalate into shakes and more stringy vegetable, baby food, cottage cheese, oatmeal over the course of the next 3 to 4 weeks. But by week 6, we'll be into a regular diet. And typically I'll recommend that a patient introduce one type of food. Studies have shown that will broaden the range of tolerated foods by 75%. In other words, you'll eat more of what you like to eat. But there will be foods that are somewhat limiting or may be somewhat bothersome. Alcohol, coffee, things that we may want to integrate at week 7 and 8 to see if it's bothersome. But overall, the patients do remarkably well, eat more of what they want to eat, and most importantly, deflecting back on the side effect profile of PPIs, 75% of patients will be weaned off of their medications. So for heartburn. So it's safe, it's effective with a high 92% patient satisfaction rate, and we get you off of the medications. So
wonderful. Yeah. What about getting back to work? When can patients go back to work after the TIF procedure? And then also exercise, able to exercise right away? Do they have to wait a little bit? I know there's a weight restriction for a period of time.
Yeah, typically I'll treat it like a groin hernia for a male, for instance, where we'll want to limit lifting to less than 10 pounds for about 2 weeks and less than 20 pounds for an additional 2 weeks. Somewhat conservative in that regard. But if you're working as far as return to work, if you can get light duty or if you work at a desk job, you can get back the next day. I don't restrict them at all.
Great. Wonderful. So we do have a lot of questions, so we'll try to get through some of these questions if you don't mind, Dr. Dargis. So we've got Rajesh. She's asking, Doctor, I have had a GI specialist talk about how narrow my esophagus is and that the scope could not pass through. Can this be corrected during the TIF procedure?
What you're referencing is a stricture or Schatzki's ring, and typically a balloon dilation would be best to again, I would want to get a pH Bravo to assess the degree of reflux, because typically a stricture, Schatzki's ring, is secondary to chronic scarring from reflux. So it's a kind of a chicken and the egg. You can dilate these very efficaciously with a balloon dilator done through the mouth endoluminally, but the duration of efficacy is between 12 and 18 months. So especially if you're younger, there are other modalities to treat a stricture other than the TIF, and something called the POEM procedure, which is a little beyond the scope of this talk, but the dilation is where I would start, a balloon dilation, and then work through it from there.
Okay. Wonderful. Thank you. Another question from Adam. How do I decide between TIF and the traditional laparoscopic procedures to treat GERD?
Well, again, I would deflect on the degree, because the laparoscopic approach, you're going to have to make incisions. It's going to be done through the belly. It's much more invasive. And most importantly, it's that side effect profile. It's the gas bloat. It's the difficulty swallowing after the Nissen. If you look at the endoluminal approach, particular to the TIF, and the long-term side effect profile, it's zero. To me, it's a slam dunk. It's the side effect profile and the minimally invasive approach to the TIF that really wins it out.
Yeah. There's another question very similar, and if there's any additional comment, because I feel like you kind of answered that with this last question, but from Johnny's asking, Dr. Dargis, have you seen patients after anti-reflux surgery such as Nissen or toupee? How do they compare post-op to your TIF patients? And you kind of mentioned it.
Well, yeah. I've the other caveat to that is I've seen quite a few patients in my practice that have had a Nissen who have chronic reflux. The duration of a Nissen is only going to be typically between 10 and 12 to 15 years. It doesn't last forever. So you've got durability there, and again, I'll get back on it. It's that side effect profile of the gas bloat and dysphagia. So I think if your hiatal hernia is the appropriate size, and you're running down that track of deciding between a lap Nissen and a TIF, it's TIF all the way.
Yeah, thank you. We have a comment, not a question, from someone. Meg is saying, I've tried going off my meds, but I got as far as 5 days and I was in agony. So that 2 weeks prior to their testing is going to be a tough one, right, for them?
Yeah. I'll work with those patients. An occasional Tums or Rolaids is okay for in that 10-day interim prior to the pH problem. But I sympathize with the many patients out there that suffer chronic symptoms and are taking double and triple the dose of FDA recommended medication.
Yeah.
There's help available out there.
Exactly. And hence the reason why we have our TIF Talks. We just really want to make sure that people get educated, they learn from physicians directly, that there are options outside of continuing to take medications or PPIs or, Tums. So this is, one of the main reasons why we do these TIF Talks. We do another question from Shane. Is a hiatal hernia measured the same by all physicians?
My comment is no. There's a vast array discrepancy in the evaluations. I'll try and reserve my comments there, but in essence, there are 3 things that need to be measured, and these are standardized measurements. There's an axial dimension to the hernia, meaning how, remember we talked about the Z line or the GE junction being at the level of the diaphragm. The hiatal hernia can raise up into the chest. So how high up that hernia raises into the chest is called an axial dimension. Mm. There's also a width to the hernia, and so there's the axial dimension, the width of the hernia, that's the second parameter that really needs to be measured. Mm-hmm. And the third is the Hill grade. And the Hill grade will tell us how loose the valve is in a different type of, it can open and close, or it can stay closed, or it can stay open for a prolonged period of time. Sure. That integrates into the Hill grading too. So in essence, when I'm looking at an EGD report from a GI doc, a general surgeon, I'm looking for those 3 dimensions. If they're not included in the report, typically I'll be limited to having to repeat the study, because those are all very important dimensions that as a surgeon, we need to assess.
Yeah, that's a really good point. I haven't heard it in that description, so thank you. So one last, I believe, question. Meg is asking, same gal that asked the question before. She said, by the way, the video was very helpful. So I'm glad you decided you wanted to show that.
Yeah.
Meg saying, after having the TIF procedure, will my chronic cough disappear?
When we obtain the EGD pH Bravo study, there's a symptom association, and that symptom association will give us a percent as to what percent of reflux symptoms will be associated with that symptom. And typically, with high symptom associations that we look for, it'll be greater than 80 or 90%. In other words, every time you reflux, you may cough. The symptom association is very high. Then I can reliably tell a patient that the cough will go away.
Yeah.
So
Yeah.
I'll leave it at that.
Yeah, no, that makes sense.
I can't emphasize enough the importance of that EGD with pH Bravo to get preoperatively to better assess the symptom association with the reflux.
Yeah, that's great. That makes perfect sense. Well, we're coming on closing time, but before we do close, I did, it is GERD Awareness Week, ironically during Thanksgiving week when everyone wants to overindulge in eating. Is there any words of wisdom or advice that you would give these patients that are suffering from GERD or, chronic acid reflux at this time? Are there any parting words that you'd like to leave with everybody?
Yes, that help is available. It's very well tolerated. It's easily performed, and there's absolutely no reason to suffer through this or take account and suffer from the long-term consequences of chronic PPI use.
Mm. Yeah, that's very, very good point. Very well said. So again, thank you for joining us today, Dr. Dargis. Was very educational. And everybody watching, if you are actually in Hastings, Michigan, or around that area, right, you can contact Dr. Dargis and schedule an appointment. Speaking of, are you doing telehealth appointments right now, due to the COVID situation?
We have in the past, and we can do electively if the patient opts to do that, yes.
Okay, fantastic. So you can contact Dr. Dargis if you're in the Hastings area, Michigan. If you're not, you can go to gerdhelp.com, and there is a physician finder there, and you'll be able to type in your zip code or look at your state, and you'll be able to find a physician that does a TIF procedure in your area. So again, I can't thank you enough, Dr. Dargis, for being here this evening. We appreciate it. And everybody that joined us this evening, thank you so much. Everybody stay safe, and we'll catch you next time. Thank you so much, Dr. Dargis.
Thank you. It's been a pleasure.
Thank you.